Hello, this is Sarah Oracle of RichSource, and I would like to introduce Dr. Bruce Werber again. He is going to cover the protocols today for knee, foot, and ankle treatment. Doctor, what are your suggestions?
All right. Well, as with all regenerative therapies, understanding the patient, their background, their needs, their activity level, the nutritional levels, and then moving into the diagnosis, making sure you have a good, solid diagnosis. You've ruled out any structural issues, such as a genoverum, genovalgum, a gastrocnemius, a torn tendon that could be giving referred pain to the ankle or the knee, especially in the ankle. A lot of times, ankle pain is related to anterior tibial tendinopathy or peroneal tendinopathy or tendinosis. So again, it's very, very critical for our regenerative therapies to be successful is to ensure that we have good diagnostic imaging and that we're clear as to what we're treating. That all said, the protocol basics are always the same in orthopedics. One, we have to create an inflammatory signal. So that can be done by the patient or the recipient experiencing trauma or surgery. Both of those methodologies cause inflammation or a release of inflammatory interleukins, causing the chemotactic pathway to be activated. Or if it's more of a chronic, older injury, chronic tendinopathy, tendinosis, or just osteoarthritis. So if those are the cases, then we're going to be doing some needling. So needling is where we take like a 20 gauge needle and of course numb the skin. We don't want to torture the patient. And we're going to perforate around and into the injured area, be it a medial lateral collateral at the knee or patellar tendon. So in the ankle, if it's around the lateral collateral ligaments or the medial deltoid, of course, when you're near the deltoid, be cautious of the medial tendons, especially the posterior tibial tendon or the flexors. But what if it is a posterior tibial tendinopathy? Certainly then you could do needling along the tendon itself, all right? So again, that's why diagnosis is so very important, to know where you're going to move from a chronic injury and you're going to cause more of an acute injury with your needling. Now, what are the other alternatives to needling? There's radial pulse therapy, EPAT, Zimmer wave are all forms of radial pulse therapy. There's extracorporeal shockwave therapy if you have access to a higher energy machine. Low energy cold laser. All of these will work. Activity, increasing the patient's walking or activity, and not having the patient take any anti-inflammatory medications, all right? So all of these methods, the key, the bottom line to what I've just mentioned over the last few moments is setting up a chemotactic pathway, getting release of the inflammatory interleukins, right? So just to very quickly summarize, we can use needling, cold laser, we can use radial pulse therapy, and we can use high energy shockwave therapy. So any of those, acute twisting injury, activity, and of course surgery all contribute to inflammatory interleukin release, setting up the chemotactic pathway for the regenerative response to follow. So, all right, so that's the basics. Now, patient instruction basics. No ice. We don't want the patient using ice immediately before or after the treatment. We actually don't want them putting ice on it for about 3 to 6 weeks. Cutting out non-steroidal anti-inflammatories. No Motrin, Advil, Naproxen, Naproxen, Celebrex, Mobic. No non-steroidal anti-inflammatories. They can take acetaminophen, all right? We prefer, especially in this day and age, minimize their exposure to opioids. But if you must, they can't take acetaminophen. You can consider a low dose opioid, but I caution against that. Not necessary to take that risk in this day and age. All right, so no anti-inflammatories, no ice. What are the positives? Patient needs to be informed. We want active rehabilitation. Now, that doesn't mean we want them going out and running a marathon or a triathlon. We want them walking. If it's a lower extremity, a knee or an ankle, we want them walking. Now, what if they have a flat foot, a gastrocnemius equinus, a structural knee issue? Well, we want to, or let's say a partially ruptured ACL, any of those issues, yes, we still want to put the extremity through range of motion, but we need to protect it and correct for any potential structural issues. So if the foot is excessively pronating, let's consider a prefab or a functional foot orthosis. If they have a gastrocnemius equinus or their post-Achilles tendon repair, let's give them a little heel lift. If they have a partially torn ACL, well, then we're going to want to brace that, but we want them walking, all right? So, again, we need to address the structural issues and make sure that we have balanced out any structural imbalances. Now, so we have each of the pieces. The last piece is active protected activity. So we want them walking. If they're lifting weights, let's say they're working on low extremity machines. We want light weights, more reps. We don't want them taking themselves to the maximum the maximum weight. We want them doing more reps at much lighter weights. All right, so that's the patient's homework. Then we want them wearing good shoes, like running shoes. I prefer even knee, hip, ankle. I prefer the patient staying in running shoes unless they must wear a dress shoe or slip-on shoe, sandal. I tell them, and once the treatment's done, then they can go back to their beautiful shoes. But while we're going through this regenerative phase, I want them stable as possible through the healing period. Now, injection. So we've stimulated the patient. We've given them post-treatment instructions. Now, how do we approach it? Well, everybody, like when we do cortisone, corticosteroid injections, we've always tried to do intra-articular. Well, cortisone, as we all know, has its major side effects. It's bad effect on the cartilage. So what we also have found out is that at least in my generation, we were taught that the synovial fluid fed the cartilage, the chondrocytes. What the anatomy and now a new school of thought is that the chondrocytes are actually being fed through the subchondral plate, through the microcirculation, from the bone marrow up through the subchondral plate into the chondrocyte attachment. So that changes how we think about how we need to apply regenerative therapy. So my advice, what I've found successful over the last several years, is that I take my dose and I inject along the capsule, around the capsule, periarticular. This way I don't need to have ultrasound imaging when I'm injecting, because I don't have to reassure myself or anyone that I did an intra-articular injection. Now, the capsule of the knee and the ankle are fairly thin, so you're saying, how does he know that he's not going into the joint? It's fine. A little bit into the joint, no big deal. You're not doing any harm. Actually, putting our allografts, our placental allografts in the joint, it does work. But it works even better when we get the allograft around into the microcirculation that then feeds the articular surface. All right? So it's not as critical application putting it around the medial and lateral collaterals of the knee, or in the prepatellar, around the prepatellar patch or pouch. So you can use your judgment. Let's say, there's a medial meniscal tear. Well, let's put more around the medial aspect of the knee, maybe at the tibial level, maybe at the femoral level, but thinking about how then the microRNA, the growth factors, the cells are going to be taken up into the healthy nutrient supply of the bone and brought to the injured area. Same for tendon. If, let's say, we're treating a tibial tendonitis, a patellar tendonitis, or a hamstring, we don't want to inject into the tendon mass. We want to inject along the tendon, preferably along the paratenon, the covering of the tendon. So that goes for the Achilles tendon, posterior tibial, the flexors, the peroneals, going parallel along the tendon and depositing the allograft along the tendon will get you much better results. So in summary, no ice, no anti-inflammatories, active rehabilitation, and do not inject into the tendon itself, and minimize your intra-articular injection. Inject periarticular, inject peritendinous along the paratenon, and I guarantee that you'll see much better results. And the last item I want to leave you with is make sure that the patient stays active, not to their extreme, but stay active so that they have protected active activity, so we keep the chemotactic signaling pathway going, and the patients will achieve a significant improvement. Now, what are the potential outcomes? 20 to 25%, we're going to report to you within 2 to 3 days. Wow, inflammation, pain are down, their activity level is improved. And then they continue to improve over 12 to 16 weeks. The more common group of patient response is 40% or so that have a day over day, week over week, month over month improvement, also in plateauing between the 12th and the 16th week. We have a third group that doesn't seem to respond in the very beginning. When you have a patient who calls you at 2 weeks that felt no improvement so far, have them come in and increase the signaling. Maybe re-needle it, shockwave it, radial pulse it, increase their activity, make sure that they're following directions, no anti-inflammatories. And still, what we notice in this third group is about 20% that they don't start to feel the improvement until about 6 weeks in. But they also plateau around 12 to 16 weeks. And there is a 10% non-responder rate that we don't really know the variables for. We haven't identified. One variable I have identified is if they're taking high-dose statins. Now, of course, we don't want to interfere with their cardiac health or their vascular health. So we have to, for these patients that are on high-dose statins, we want to increase the signaling, increase their activity, increase the needling, shockwave, etc. So those are our groups. So 10% non-responders, about 20 some odd percent slow responders, need increased signaling, 40% week over week, month over month improvement, plateauing 12 to 16 weeks. And the first group, the miracle group, as I like to call them, almost immediate response within days. Now, there are a group of patients, I don't have a real number, where they note they have achiness, discomfort from the injection. So just be aware, tell them to put on moist heat, and 2 or 3 days that injection discomfort goes away. Now,
okay, Doctor, thank you so much in our series.
One more thing. Be very, very careful. Prep the skin. Make sure you use antiseptic. The biggest thing, potential, is that you created infection because your sterile technique, your injection technique was not clean enough. Make sure you're wearing gloves. Prep the skin. Make sure all of your equipment is clean and fresh. This is very, very, very important. Thank you. My pleasure.
Thank you, Dr. Werber. Very helpful. Thank you in our series that we will continue.